Thank you, respected chairpersons and speakers, for a great session, and propitiously we are on time. So the second session is probably the field which is now the most exciting one in cardiology today, and that's interventional and structural heart disease. And I call upon Dr. Anmol Sonawane and Dr. Nihar Mehta to please start proceedings. And
I've just got a timer here because you all so promptly said you're on time, so I'm going to do my best to actually give you a little extra time as well.
So let us take 1 second to at least introduce Sai to the audience.
I think Sai is one of the structural heart specialists from Chennai Apollo. His core expertise, in addition to structural, is he's pioneer and one of the highest volume mitra clip operator in the country. And if we'll keep talking about Sai, I think we'll delay the session. So I think without taking much time, I'll just say I think we should proceed with Sai's talk.
I think both Anmol and Nihar are being too kind. Before I begin, I want to express my profuse gratitude to Dr. Pelajani and Dr. Satyavan Sharma for having me here, and the organizers of AOC for having me here with you. Always love coming to Bombay, always love being part of this group. It's amazing to be considered for this academic forum year after year. Thank you all for having me here. My topic today was to discuss how to address mitral and tricuspid regurgitation. And I thought, in all honesty, I will not veer from my field of expertise, where I could have given a bunch of examples which were theoretical, which are not yet available in India, on the present treatment options, or I could talk to you about what I have first-hand experience about and what is available in India. At present, for both degenerative and functional mitral regurgitation, the device available in India is only the Abbott MitraClip system. The Pascal is slated to come in, which is the Edwards system, is slated to come in about a year from now, but none of the other devices, the native mitral valve replacements, none of them are available as of today, and they're at least 2 to 3 years out of us even looking at them. So with that, with the permission of the chair, I shall proceed. So heart failure is one of the biggest conditions that we will see as cardiologists going forward in the future. The estimate is that there are about 26 million cases of heart failure diagnosed worldwide, and about 37 to 38 million if you consider the undiagnosed cases. We have a 1 in 5 lifetime risk of developing heart failure. It's the #1 cause of hospitalization in the world today in cardiology, and more than 50% of these patients will get readmitted within 6 months of discharge. Several reasons for this: increasing life expectancy, skyrocketing incidence of hypertension, obesity, diabetes. The heart failure patients have a very morbid course in hospital. 30% of them will die, and over 55% of them, as I mentioned earlier, will get readmitted. Mitral regurgitation is a significant component that worsens outcomes in these heart failure patients. Now, you have two types of mitral regurgitation. One is the degenerative mitral regurgitation, which involves damage to the chordae, the papillary muscle, or the valve tissue with rheumatic heart disease or other conditions that cause the valve to non-coap properly with normal LV function usually, and then cause mitral regurgitation. And the second component is the functional mitral regurgitation, where there is a pathology involving the LV, cardiomyopathy, whether ischemic or for whatever origin. The LV dilates, the mitral annulus dilates, and you have non-coaptation and you have mitral regurgitation. So mitral valve disease is 2 to 3 times that of aortic valve disease, the disease burden, and even in a country like America, only 1.5%, about 4 million cases of MR are diagnosed annually, and only 1.5% of them are treated. MitraClip is a refinement of the surgical Alfieri stitch. It's a mechanical solution to a mechanical problem, and once you deploy the clip, a tissue bridge is created by endothelialization of the clip, creating a double orifice. Now, the first concept and first in man was in 2003, and it had a very rocky course over the last 20 years. The MITRA FR study came, which showed, I think basically, I don't want to discuss data on a Sunday morning, but what FR did is, they took cases that did not benefit from MitraClip in a very morbid group of functional MitraClip functional MR patients where the LV size was too much, the EF was too low. When COAPT came, the one thing what COAPT did is the first thing it proved is that in secondary MR, MitraClip was safe. The second thing it proved is there was durable reduction in MR, there was reduction in heart failure hospitalization, there was improved survival, and the quality of life of almost all the patients who got the clip was better. Not only that, it was the only device at that time that showed a reduction in all-cause mortality in the treated group. Now, if you compare your mortality from statins, I think in the best statin studies, you have about a 1.2% mortality benefit from taking statins. MitraClip in HITS cohorts showed almost a 19 to 22% mortality benefit, which is unheard of in any therapy till today. So, moving on, MitraClip is the first therapy to show improved prognosis by reducing heart failure-related hospitalizations and reducing MR in patients with severe LV dysfunction. So what did EXPAND do? EXPAND was inspired by the fantastic results of COAPT. So it had two arms. It had the functional arm, like COAPT, which was only for FMR, based on which data the US FDA approved MitraClip. And then it looked at the degenerative also. And just as expected, the results matched both the functional and degenerative arms by showing all the benefits that we noticed. With that data, I'm going to move on to some cases. The first patient I have to discuss is an 89-year-old male weighing about 36 kilos, old antral MI in 2000, large anterolar scar, severe LV dysfunction, EF less than 20%, progressively worsening, severe MR since 1 year, 6 hospitalizations in 4 months, unable to be discharged from the hospital this admission, CCU for 45 days, in and off went, planning a tracheostomy, and at that point of time, I just want you to take this video in and look at this LV. The LV is 9 centimeters. EF is less than 14-15%. He's on milrinone. He's on every possible support, on dobutamine. So at this point of time, all the family wanted was they said, we want him to come home and pass away. So I said, it's a really expensive option for something like that. But India is a self-paying market, right? And I said that this is the kind of case that I should walk away from. Because almost all the criteria show that his chance of surviving, there's a 90% chance he'll die on table. If he survives, there's a 90% chance he'll die in hospital. If he survives, there's a 90% chance he won't be alive for the first 6 months. This is the consent I got. But children are from the US, UK, they said, we can't see him in hospital, we just want him to go to his house. So this was the LV. EF about 13% when I started. Horrendous MR, almost across the entire length you can see in the bicommissural. So managed to get one clip, you can beautifully see the beauty of the MitraClip is extremely stable. So as long as you don't make sudden movements, there's no damage you can do. So you go in, you make small movements, you make sure you don't touch anything, and this is such a roomy LALV, you can play football in it, right? The acute MRs are the tricky ones. So you can see how you can line up the clip beautifully, and in bicommissural, you position it where the MR is. So medial to lateral, you get the position, you put an X-plane, and then you look at the leaflets at that exact point. And you align up the clip to be coaxial to the leaflets. That's what takes a little trick. Because then, when you pull them together, you don't contort the valve. So you get it nice and coaxial. You can see the grippers come down. You close the clip, severe MR becomes 0 MR. Right? Now the next thing that happens when you do something like this is the EF becomes sub 10%, because this struggling LV is not able to deal with the afterload. And we have learned how to deal with this. First of all, I have to commend my brilliant heart failure team, which Dr. Abraham Oman, I don't know how many of you know. But what they do is we put him in the ICU, we give him Pressas for support. Irrespective of the creatinine, we give him Lasix to reduce the LV volumes to dry him up. So if I see creatinine going up to 2 in an 80-year-old, I'm actually happy. And then we give dobutamine to keep the LV going, and if it is arrhythmogenic, we take it off and give levosimendan, and that's it. So we just hold our ground for that 2 to 3 days where the LV recovers from the kick it's getting. But the beauty is the benefit from the forward cardiac output far exceeds the detrimental effect of the afterload on the LV. And they just bounce out. So you can see how it looks, almost no MR. LA pressure from 44 down to 32. In just a day, post mitral clip, he's off ventilator, off all supports. CVP from 28 is down to 10. If the audio was there, he says, this is the first time I remember how it feels to breathe normally. So he stayed in hospital for about 6 days, and then he went home. Fingers crossed, I hope my third prediction also doesn't come true. He escaped the first two. So you say, okay, Sai, this is 4 days later. What about longer? The second patient I have to discuss with you is a 72-year-old male, a diabetic and hypothyroid, PCI in 2005, severe biventricular dysfunction, EF 25%, worsening on max medication, 2.4 azotemia, liver enzymes off, lactate 9.6. First air ambulance refuses to take him. Second air ambulance, they cajole, they threaten, they say they will sue them. They managed to bring him to me with 70 systolic pressure, with lactate 9, crashing. So I take him into the lab, and this is what I see. A non-moving LV. My anesthetist says, look, I'm purging pressors. I'm not going to be able to extubate him ever. So my plan was torrential MR, huge non-coaptation, almost 1 centimeter. And at this point of time, we didn't have the XTW and the XTR and the big clips. I had the obsolete NT, the tiny clip. So this was turned down by, when I asked for opinions, it was turned down by the international operator saying that you won't even be able to get the leaflets together. So my aim was to go in, get one clip towards the edge of the gap where the NT would reach, leave some MR, and then, see, they've paid almost 30 lakhs to get him to me, air ambulance, this, that. See how he does over 4-5 days, and then take a call. So managed to do the septal punter, got one clip in. You can see the 3D is so beautiful, and this is what is so pivotal, and this is what gives you long-lasting good results in mitral clip, is to always have your clip coaxial to the line of coaptation. Center, 12 o'clock. As you go towards the size, you go towards the valve. So I left a little bit of the gap, put one clip, and my plan was, I put the clip medially, all I have to do is go laterally, put one more clip, let me see how he does. So put the first clip. Anesthetist says, what the hell are you doing? Whatever you have done, the heart loves it. I'm coming down on pressors, lactate is improving, CVP from 32 is falling. So waited 15 minutes, took a second clip. Now you can see in this image, does the pointer work? Yeah. So you can see the first clip is in the LV, the second clip is in the LA. So go right, nice and next to it. And I have a cool trick. I line everything up in the LA away from the clip because I don't like touching that clip. And then what I do, I just use the lung volume. If I go lung down, the clip sails medially. If I increase tidal volume to 500, the clip moves laterally. So depending on where I want my clip to do, I get it nice and coaxial and then just go lung down, apply the second clip, and you can see the huge non-coaptation gap is now a clean line with 2 clips in the center. Went from severe MR to nothing, LA V wave from 84 to nothing, lactate from 9.57 to 1.36 on table, CVP from 32 to 6, systolic pressure from 80 to 130. Over the next 3 days, creatinine reversed, liver function normalized. This is 12 hours after the procedure, that is 36 hours after the procedure, that's 4 weeks after the procedure. So you say, okay, Sai, that is 4 weeks. So it's about 10 minutes I've spoken for now. Is the speed okay? Should I go faster, slower? All right? Okay. So you say 4 weeks. 80-year-old male, 2.5 creatinine, severe MR, multiple hospitalizations, same story. Put one clip, huge non-coaptation gap. Severe MR becomes nothing. You can see the non-coaptation gap again. Again, 86 LA V wave down to 31. This is him at discharge. Every day over the last 5 years, he has sent me a message saying, good morning, sir, thank you for this miracle. Because he was diagnosed of ILD, renal failure. Every single day that his father is alive, he wakes up in the morning and says, sir, thank you. If not for you, this could not have happened. This patient I didn't think is going to survive past 1 month. Not only did he do well, but 4 years later, he went to San Diego to visit his grandchildren, and this is a photograph from his trip. So this is 4 years later. So MitraClip works acutely to bail you out. The results are sustainable, provided you have good echocardiographer, you have a good heart failure team, and you choose your cases wisely. So this is a patient who was airlifted to me from Hyderabad, bedridden for 1 year, severe refractory heart failure, once in 3 weeks hospital, getting IV Lasix. People said that, what are you trying to do? Why are you trying to do a MitraClip in a bedridden patient for 1.5 years? When I looked at him, all I thought was that the only reason he's bedridden is because he cannot walk. He's forgotten to walk. Convinced the family, did the clip. 1 month later, he's watching television. Son says, of all things considered, I think it's okay what we did. So I said, okay, 1 month later, you're okay. The old man then learns to stand up and sit down and relearns how to walk with physiotherapy. This is 3 months later. Can you believe this is him 6 months later? Not only did he withstand all of COVID, but his family were calling me to tell me that he refuses to keep a driver. He wants to drive. Please convince him, doctor. And this is 5 years later. His daughter is sending a message saying, my grandchildren are lucky to have him. Thank you for this blessing that you've given us. So, acute MR. So now we have done a series of functional MRs. We have seen the worst cases, how they do over 5 years. Acute MR, 86-year-old man, acute inferior wall MI, papillary muscle rupture, flail P2, severe MR, cardiogenic shock, again lactate rising, unable to get off the ventilator, called me from Bangalore, airlifted him to Chennai. You can see now the LV, the inferior wall, dragging the posterior mitral leaflet, the ruptured chordae, the overriding, severe eccentric jet. Now these are really tricky cases because your LA is only 2 centimeters. So your maneuverability is very less inside. So anyway, went in, balloon pump, almost, even before I straddle, I'm inside near the pulmonary vein, pull back, avoid the left atrial appendage, turn down, again, get my 3D enforce right, single clip, you can see the leaflets nicely bouncing, you can see the leaflets once they are trapped, clip closed, severe MR to no MR, went home, 3rd day. And the normal LVs do really well. But the challenge with the normal LVs is that because the LV is kicking away like this, the clip has a tendency to peel off the leaflets because these are 85, 87-year-old leaflets. So what you do in these cases is heart rate less than 60, blood pressure 100 by 60, filling pressures as low as you can. You tell him your dad's going to be giddy, he's going to get up and have postural hypotension, I don't care. Make sure he doesn't fall, make sure you stand with him, let him be giddy, give me 3 months for the clip to endothelialize, then you pump the pressure up to what you want. And they do beautifully. This is him 1 week later playing with his great-grandchild. So again, the first case was an 86-year-old lady, extremely fit, playing badminton, swimming, one of the last royal families of Tamil Nadu. Then she, while playing badminton with her grandchildren, ruptured her cord, 6 hospitalizations, surgical turn down. This was the first case we did. The reason I'm showing it is, put one clip, got 50% reduction, put a second clip, got 90% reduction. You can see the huge flail segment went to nothing. You can see the big flail tissue, myxomatous valve, again, 46 LA pressure to nothing. This is her day 1, day 2 at discharge. Went on to play badminton in press a week later, and now it's 6 years post-clip. After 2 COVIDs and a pneumonia, she's still fine. So we published the first 10 cases. I'm publishing my first 90 cases with follow-up for 1 year. And this is the Asia-Pacific guidelines, which we helped co-author, saying that the Asian valve are smaller and they require finer nuances to treat than the standard European guidelines that we have. Hopefully, it'll be out soon. I have another 5 minutes. I thought I'll show you some fun cases, just maybe 2. We have time for that? We have? So, 42-year-old surgical gastroenterologist, restrictive cardiomyopathy, 39 kilos, moderate MR for 10 years, now severe MR, severe TR, short chordae, mitral arcade. Look at that. Giant LA, giant RA. Again, multiple center turn down, huge MR, huge TR. And the leaflets are like this. What will you clip? But when you look, both the parents are IITians who fell in love, married, worked together for 40 years. And they helped develop the ultrasound technology that's in the latest Philips machines. And they brought their daughter, who is an AIMS surgical gastroenterologist, who says, all I want to do is operate till I die, right? So had to attempt it, went in, put one clip, managed to get the clip, managed to get an excellent result. I said, I bhago sala idhar se. Got out, 4:30 in the morning, I get a call. She's gone in for, before that. The minute I put the clip, she starts desaturating. So my anesthetist says, Sai, the LA pressure is dropped. Now the RA pressure is sub-LA pressure. She's shunting, you can see the TR jet is directly on the septum and she's shunting torrentially. So no problem, put an ASD closure device, nice and clean, go home, sleep peacefully. 3 o'clock in the morning, flash pulmonary edema, what are you going to do? Go to the hospital, 4:30, get her to the lab, do the TEE, clean peeled off the AML. You can see the clip hanging on the PML. Just hanging. Now, you can see the nice little tear to add to my fun. It's torn off the AML, sticking to the PML. She's sicker than she was. I don't know why. Now, I can't leave her like this with one clip flapping around. These are the early years of MitraClip, mind you. And, you know, we have enjoyed some good cases. So take her in. The first thing is the septum is paper thin. If I do something to tear that septum, it's death on table because restrictive cardiomyopathy, giant LA, giant RA, surgical backup is not there. So what I do, I take a 65 centimeter pediatric sheath, I keep it in the RA. Then I lasso the knob of the ASD device in real time. Once I lasso it, with echo guidance and fluoro, I move the sheath to support the septum. So the septum can't tear. And then I milk the ASD device out into the sheath, while the 65 centimeter sheath supports the septum and prevents it from tearing. So then I take it out. So the first hurdle is crossed. Then I go back in, use every skill I've learned till now, and a lot of prayer. Put one clip below, put one clip after. And these are all NTs. And what I realized is, if you pack these clips tight enough, the gradient doesn't go up. You don't produce mitral stenosis. But you have to have the courage to go down, cut that respiration, go all the way next to the other clip and catch it. And I put one above, one below. Severe MR became even better than before. Before she had mild MR, now she has trivial MR. And this is a message from her. Now she's waiting for her tri-clip. So I took the same device and closed the whole back. So this was a really nice case where I said, sir, good morning, did a couple of pancreatic surgeries today, got discharged successfully. I didn't have any difficulty standing for long hours. SLDs and SLDs. We have done some crazy cardiomyopathies, huge gaps, large LVs, EF 24%, 20 years cardiomyopathy. So I go put two clips, and you can see I got a beautiful result. One on the left, one on the right. And got good gradients, and next day patient comes off with one clip flapping off. Because the LV is so large, the LA is so large, they're just pulling on these clips. So you can see one clip, both the clips stable, and you can see one clip wobbling. So you can see here both clips stable, one clip wobbling. And you can see how you can align everything up, time it right, go right in between both the clips. And if you catch it just right, it's just magic. Everything stabilizes. Patient did really well. Coming to tricuspid. Okay, I have 6 minutes, so I'll finish with the tricuspid case. 56-year-old lady, 42 days in hospital, refractory biventricular failure, cardiogenic shock, unable to get discharged, severe MR, severe TR. Look at the RV size, look at the LV size, look at the MR. Now, in about 35% of the patients, when you treat the mitral regurgitation, the tricuspid regurgitation becomes better. But her RV function was horrible. Her liver was congested. Her liver enzymes were off. INR was 2.4. So anyway, went in, very quickly put one MitraClip, and then looked at the tricuspid. Now the tricuspid, this was my first tricuspid clip. It was a whole different ball game. There are two ways of doing it. One is you go from the right side, and then it lines up nicer to the valve. And the second is they say you miskey. But the way I look at it, I am used to a certain way the device behaves. And I wanted to remove all the variables that I was not used to. So I went from the same side. I did not miskey. Because at least now, I know by muscle memory, whatever I do, how the clip will behave. So went in, managed to get a great grasp between the posterior and the septal leaflet. I mean, between the septal and the anterior leaflet. So you can see in the MPR, I've got a nice position. This is the anterior leaflet, posterior leaflet, septal leaflet, nicely there. Got the clip leaflets in, put it in, pull them together, and that is the final result. You can see beautifully septal leaflet, anterior leaflet tightly together, posterior leaflet coming in. There was still moderate MR. But I left her like this because I tried to get a second clip in and I didn't even know where to go. It went all over the place, so I just said, okay, get out of here. This is pre-TR. This is post-TR. This is her LV exactly 3 months later. Look at the RV. RV function normal, liver enzymes normal, EF from 20-odd% to 45%, LV size smaller, RV size smaller. Look at the beautiful coaptation between the posterior leaflet and the mitral clip. So what happened is all the volumes came down. MR became non-existent. I had to go completely off axis to find one small jet. TR became non-existent. It was almost zero. And what had happened is that with the reduction in MR and TR, the annulus of both the valves shrunk and brought the posterior leaflet and coapted nicely the anterior leaflet. And she did beautifully. I'm not going to go for this case. I just want to show you this. 55-year-old doctor from Colombo, post-mitral repair with a 25 millimeter St. Jude's ring and with Gore-Tex cords, came to me with 15 years later, 2008, came to me 15 years later in 2022 with the cords failing. And he said, I'm 55 now, fit guy. He says, if I go to a surgeon, he cannot repair this valve. I want you to look at this valve. Nobody in their right mind would think of attempting this valve. So he said, if I go to a surgeon right now, Dr. Sai, he will replace my valve. And by the time I'm 65, I'll have to have a second procedure. Even if I have a transcatheter procedure by 75, I'll have another procedure. If you can give me even 5 years with your clip, I will take it and run for the hills. So I said, I'll give you 2 years, but only after I attempt it. So there were several technical challenges, went in. What I had to do, if you look at the image here, is I had to first position centrally and then sail under the ring to catch all that extra tissue and use only that small 2 millimeter maneuverability and catch the leaflet only in diastole, because in systole I'm hitting the ring. So timed it correctly, got everything, finished with a post-procedure gradient of just 3. Even in this small valve, even with the annuloplasty ring. So, severe MR to no MR, if you catch it just right. And this is him 2 years post TTE. No MR. Thank you so much. I finished with 1 minute to spare. Thank you.
Thank you very much, Sai. Some really exceptional and challenging cases. We'll keep the discussion for
Perfect.
after the next talk.
Thank you. Thank you.
Well, let me